Okay, all right, now let's talk about maintenance. We spent, I don't want to bias the discussion too much, but we spent, there was a period of time when rituximab maintenance or maintenance with an antibody was very, very commonplace in follicular lymphoma. At least in the U.S., I think the vast majority of people were given maintenance therapy. And then we've gotten away a little bit from that. John, why is that?
You're right. The pendulum has come back to the center, and maybe it's even swung to the other end. And in fact, I think, now we're probably doing maintenance therapy in maybe a quarter of our patients, where we used to do it in all of our patients after induction therapy. I think, we've learned a lot of things, right? In the right patient, there might be a role for maintenance, but in general, that additional therapy over a couple of years can really be associated with a lot of morbidity. And the biggest thing that we see is hypogammaglobulinemia that lasts for many, many months, if not forever. Even potentially neutropenia that's significant, and that risk for infections can be very problematic. And what kind of infections are problematic in my clinic? They're typically upper respiratory infections, sinusitis, and you say, well, geez, those are things we can deal with, but they're actually kind of nuisance infections to deal with. That sinusitis is something that they come in and they continue to tell us it's a problem for them, and you know that it's been simply because of chronic B-cell depletion. So I'm not as big a fan of it as I used to be. I think there's a little bit of a learning curve that we had that took actually quite a long time.
Yeah, but there are some patients whom you have that discussion that we don't know that we don't think it's going to change overall survival, but it does change progression-free survival, and having that control, I think, helps some patients, at least from a quality of life type of thing. But so then the question is, what antibody do you use, and how long? Matt, you want to tackle that?
Yeah, so I've standardly, depends upon what I gave during induction. So if I gave chemoimmunotherapy, often I'm giving it and I choose, and after what ends up being a long discussion with the patient, we choose to proceed with maintenance therapy. If I gave chemoimmunotherapy, it's every 2 months for 2 years. I have not extended beyond 2 years to 4 years, where there is some data. I think the PRIMA data still remains pretty impressive. At, I think, 10 years, over half the patients are still alive. Some of the time needed to next therapy, which I think is a big deal when you talk about follicular lymphoma, is impressive in the maintenance arm. But I am the first person to be having that discussion with my patient, that if I start to see infections, even one that's delaying therapy or affecting their quality of life, because we have to remember what maintenance is about, right? It's to allow them to maintain their quality of life. So if they're suffering and you think it's because that you're doing rituximab or some other monoclonal antibody maintenance, then it shouldn't continue. I think it is kind of interesting, because we now have other modalities like subcutaneous rituximab. So we've made it easier for patients to get maintenance therapies. But the pendulum is shifting, and what's driving that is I think a lot of thought about what's the end game in these patients and without survival.
Yep. I totally agree with my colleagues. So we are using maintenance treatment with rituximab in more than 15-20% of the patients, because at the end of the day, it's a balance. So, okay, you can increase the median the progression-free survival according to the PRIMA study. There was an update at 10 years presented 2 years ago at the ASH meeting by Zil. But anyway, the overall survival, there is no difference in terms of overall survival. And on the other side, the problem is infections, neutropenia sometimes, thrombocytopenia for several months. So it could be tough. So at the end of the day, I try to use this kind of maintenance treatment only in a selected patient, where I think could be important to reduce the risk of a relapse. But in at least 80% of the patient, I avoid this kind of maintenance.
So in that 15 to 20% of patients that you do potentially use it, what antibody do you use? Rituximab.
Every 2 months for 2 years.
For 2 years. There was data from Matthias Rommel and the Still group. They're looking at 2 versus 4. What's your, what do you think of that?
So if it's quite toxic to use for 2 years, could be a real problem to continue for other 2 years in terms of neutropenia, risk of neutropenia, infection, and so on. I think 2 years is okay.
Okay. Yeah, there was there is data that was concerning about increased mortality when using rituximab maintenance after, I think primarily would have been atezolizumab after bendamustine bendamustine regimens, but the data from the BRIGHT trial, which is a randomized trial, but the patients who got maintenance therapy was not randomized, that it wasn't worse. Bizarrely, it was actually better. I don't think anybody believes that improved survival, but it gives a little bit of comfort that if you're doing that in that setting, that it's reasonable to do that.